Hi everyone, this is Tim, your Block 1 lecture instructor, and we're going to be covering respiratory system disorders today, and it's a pretty simple PowerPoint in VoiceOver, so kind of bear with me, and I'm actually going to read some stuff that I found not only in your book, but also on the internet to kind of keep it as basic and simple as possible, so try not to be too bored, and I'll try to entertain you as much as I possibly can. Alright, so respiratory disorders that are viral infections, they are the smallest of all microorganisms. The scope of infections run from the common colds all the way up to AIDS and HIV. Antibiotics have no effect on viral infections, so for when you have a patient that comes in either to a clinic or a hospital and they feel that they're dying from the cold or the flu, really it's just a viral infection, and the only thing you really can do is really just treat the symptoms until it goes away. Antiviral medications are available for some viral medications. You could take Tamiflu for the flu. It's usually one pill. I think it's taken once a day for roughly 5 days. But what it does is really just speeds up the process of the flu, not necessarily get you, better because of the pill. So the common cold is most contagious 1 to 4 days prior to the symptoms, and it'll last through the first 3 days. So for those of you who actually have a cold, look back as far as when your cold had started and then find out a week prior to that who you've come in contact with. Usually that's the person who had gotten you sick. But as far as, if you're sick today, you didn't just get it yesterday. So transmission occurs most frequently from contact with contaminated surfaces. Usually it's, I think of it this way, that, we constantly are touching things with our hands, but we're constantly touching our face. It's the fingers in the nose, fingers in your eyes, fingers in your mouth. That's where it really transmits. So keep your fingers and your hands out of your mouth, eyes, and nose. So rhinorrhea is a nasal congestion and cough. It will increase the mucous secretions. So basically, like I said, you got the common cold or you got the flu. You're really just treating the symptoms until you can get better. Most common symptoms are the runny nose, the nasal congestion, the cough, and the copious amounts of drainage from your head. Common cold medications are most of them are sympathomimic. They contain pseudoephedrine, analgesics, or antihistamines, generally safe for children for older than 6 years old. Call your doctor before taking it if you have either heart disease, hypertension, or thyroid disease. Most medications for the common cold will interact with people with their blood pressure medications, so definitely check with your doctor first. Side effects of this word, it would be headache, nervousness, increased blood pressure, and insomnia. Side effects of antihistamine is usually drowsiness. The Benadryl tends to do really well with the symptoms, but for most people, it actually knocks them out. That's why most nurses who can't sleep real well will take Benadryl before they go to bed. They'll take Benadryl and wash it down with wine. That tends to happen too, but it works. So second generation antihistamines, they're non-sedating antihistamines, which could be Zyrtec or Claritin. They have little to no effect on sedation. I typically take Zyrtec every day, and it works, unless the allergies have gotten so bad and then it just doesn't, but nothing works at that point. But I don't feel drowsy or I don't feel sedated or anything. So for cough medications, we have antitussives. They act on the medulla to suppress the cough, increase effect with other central nervous system depressants. The expectorants, they loosen bronchial secretions. They're found in combination with antitussives and analgesics and can cause nausea and vomiting. So when I usually either get a chest cold or I tend to sleep on my back, so when my head drains and it lands in my chest, I tend to take an expectorant and a suppressant. The suppressant will quiet my cough, but the expectorant will at least break stuff up and kind of thin it out a little bit. Plus, I think that the more water you drink, the thinner things get too. So nasal and systemic decongestants, they produce vascular constriction within the nasal mucosa, so decrease in the fluid secretion. So if you take a decongestant, usually it will obviously allow your nasal passages to allow you to breathe a little better, but a lot of times they dry you up too. So We have nasal sprays and we have drops. You can get something called rebound nasal congestion. This is where you tend to keep taking the nasal sprays to the point where they are no longer effective and they are now working the opposite effect. My dad had bad sinuses when I was growing up, and he used to use nasal spray. I don't know, he'd probably go through a bottle every day or so because he was just always so congested. But then it got to the point where he became, I don't want to say addicted to it, but it was just he couldn't breathe without it. And I'm assuming that he probably, after so many years, probably just had the rebound nasal congestion. So basically he was spraying stuff up his nose just to try to see if it would give him some relief, but it really didn't. So see here, this may cause the client to be jittery or restless. Sometimes, like I said, with the vasoconstriction of these decongestants, it will kind of make you feel a little jittery. Avoid caffeine because it's also a vasoconstrictor, and check with your physician if you're on a beta blocker because it will kind of mess with your blood pressure meds. All right, so this is where I kind of turn to the internet and your Iggy book in order to find out information based on these common disorders based on the respiratory system. So like I said, kind of bear with me a little bit. I will go over the slide, but then I'll kind of read to you or kind of go over what I found and what I find that's probably either most interesting or that I really, really want you to pay attention to. So with valley fever, it's a fungal infection. It occurs in the soil of the Southwest. It's often asymptomatic, or symptoms are similar to the influenza, usually resolve without treatment. In the worst case, pleuritic pain, arthritis to the knees, ankles, systemic infection of the skin, meninges, and the brain is less than 1%. So what I want you to know about valley fever is that, one, because we live in the desert and because there is so much construction in Phoenix and in the surrounding cities that we're actually very susceptible to getting valley fever. It is found in the soil. It is spores. Usually the patients that I've taken care of will come in with symptoms of valley fever based on us having some sort of windstorm or the haboob or whatever you want to call it. It's pretty much picked up the dust and it literally just has spread it all over the city. Those who have just moved here are the ones who usually get it. If you've lived here for either all your life or at least probably the last 10 years, maybe in 5 years, you have built up a resistance and a tolerance for valley fever. So I've been here for about 23 years, and at some point I may have had symptoms of valley fever, but my immune system was strong enough to really get over it. So I don't think that it really affected me that much. But again, usually September in the fall when the haboobs come and it starts to kick up all those dust storms and stuff, usually that's when I get my patients that come in with the symptoms or shortly after. And usually it's from people from the Midwest or usually Ohio, Indiana, Illinois area stuff. So kind of pay attention to them. According to what I found on the internet, let's see here, the valley fever symptoms are going to be fever, cough, chest pain, which is more from probably the coughing so much. And then you have the chills. And you have night sweats, headaches, fatigue, joint aches, and possibly a red spotty rash. I've never really seen the rash on my patients before, but I have seen all the other symptoms. And again, they really just mimic the flu or the common cold, or just feeling overall malaise. So with a chronic valley fever, or people who can't get over it, this is where it progressed from acute to chronic. That symptoms usually will be low-grade fever, the weight loss, the coughing, the chest pain from the coughing, blood-tinged sputum because you've been coughing so hard for so long, you start to kind of break up those capillaries, and that's where you start to get a little bit of bleeding, not enough that it's hemorrhaging or you're spitting up blood. It's more of just your coughing, and you do get that little tinge to it. And eventually you'll form nodules in the lungs. Because it is a fungal infection and because it's in your lungs, your body will try to protect itself by encapsulating those spores and trying to wall them off. So that's where the nodules come from. Let's see here. What else did I find? Medications. So the physician may actually prescribe antifungal medications such as fluconazole or antifungal medications for chronic, or people who actually are having the chronic valley fever. So the fluconazole or the diflucan. They also have sporanics. Are usually the most common for these things. They'll put them on it for usually about 14 days and try to see if they can get over it. The fungal medications themselves usually have a side effect of nausea, vomiting, abdominal pain, and diarrhea. That's just because it's really hard on your system. So, but after about a week or so, you should start to feel better. As far as tests that they will probably run in order to determine if you have viral fever, they'll usually do a sputum smear or culture, and they'll also do blood test to check to see if you actually have antibodies against the fungus. And if you do, obviously they're going to put you on the medication. So I think that's pretty much all I really want you to know for viral fever. Again, it's really more of something that really hits the Southwest. It's for the patients I've seen, usually it's because of the dust storms and being affected by it. And again, if you've lived here long enough, you've probably either been exposed or possibly maybe had it just enough that your body was able to fight it off. So. All right, so for lower respiratory tract disorders, we've got pneumonia. The etiology and the pathophysiology are inflammation of the lung tissue, usually caused by an infectious agent, which will either be bacterial, viral, fungal, or parasitic. It can also be caused by inhalation of chemicals and aspiration of gastric contents. The lifespan consideration, especially with the elderly, the older you get and the less likely you're able to fight off infections and stuff, they'll really tend to get pneumonia more often. It also causes less air exchange, and the more air and secretions remain in the lungs. So you take those big, huge, deep breaths, air may get in, but it won't really go very deep, and it starts to affect your system. So let's see here. What did I find on the internet for pneumonia? So pneumonia is an infection that inflames the alveolar in one or both lungs. They'll fill with fluid or pus and causing cough or sputum that is pussy. They'll cause fevers, chills, and difficulty breathing. Pneumonia can also range from anything from mild to life-threatening. I've had young people who've had pneumonia. They call it walking pneumonia, or they generally feel the malaise, but again, their body's able to fight that off and try to treat the symptoms of it. Those who are actually very old or very young, especially with children, that really bothers them because their immune systems aren't as strong enough. So antibiotics and antiviral medications can treat most common forms of pneumonia. I know in the hospital we usually put people on Levaquin or levofloxacin, the same med. They tend to do pretty well. Signs and symptoms of pneumonia include the fever, sweating, and shaking chills, lower than normal body temperature, coughing, chest pain, which is because of the coughing, shortness of breath, fatigue, muscle aches, nausea, vomiting, diarrhea, and headaches. And that's pretty much about it for the symptoms. Again, it's really I think of it as people who have the flu and flu symptoms, and they have just gotten worse and progressively worse to the point where again, you'll eventually go to the doctor and he'll put you on some sort of medication. So they also have community-acquired pneumonia. This is most common type of pneumonia. It usually occurs outside the hospitals it occurs in outside of the hospitals and other healthcare facilities. Usually these are long-term care facilities. The elderly, again, they're very susceptible to getting pneumonia, and then put them all together in one big, huge facility, and they tend to spread it around to each other. It is usually bacterial. It's again community acquired. They're going to treat the symptoms, put them on an antibiotic, and wait for them to get better. We also have hospital acquired pneumonia, which is usually patients who come to the hospital who don't have pneumonia, and then usually we have transported it from one patient to another. And again, or a lot. In fact, the example that I found was people who are on a breathing machine or a ventilator are often in ICU. They're at a higher risk because of the sterile technique not necessarily being followed. So hospital-acquired pneumonia is basically the healthcare provider has given it to them one way or the other just through being in the hospital. So. We have aspiration pneumonia. Basically, and I've mentioned this before, patient doesn't swallow too well and they eat their food, they swallow too fast, and it just goes down the wrong pipe, as my mom used to call it. And you aren't strong enough to cough that stuff up, and eventually it just becomes an infection. Your body tries to fix it, and it just doesn't work. So let's see here. All right, so as far as determining whether or not you have pneumonia, they're going to do chest x-rays, and you already see that on your PowerPoint here. And they'll also do blood tests to confirm the infection. They'll do a sputum test. That's pretty much about it. Again, I told you about the antibiotics. It's usually Levaquin. If it's antiviral, or if it's viral pneumonia, they will tend to, they could put them on the medication for the flu, but most likely they don't. And again, you're just going to treat the symptoms. So I think that's it for that. One thing you can actually do to prevent pneumonia is actually get your patients to get the flu shot and the pneumonia vaccine. So that's it for that one. Let's see here, we already talked about the signs and symptoms. It's subjective. It's the dyspnea, it's the chest pain. It increases with inspiration. The objective signs and symptoms are usually fever, chills, increased white blood cell count, cough, purulent, sputum, crackles, and bronchial sounds. So again, it's going to affect their lungs, and you're going to be able to see it and hear it, and your tests are going to prove that. So. We talked about the chest x-ray and the sputum culture. As far as collaborative care, we talked about drug therapy. We also talked about the nursing assessment. You're going to, when you do a sputum sample, you're going to look at it, you're going to describe it, and it's going to, you want to know the color, the amount, the consistency. You want to listen to their lungs, and you could possibly have mental status changes, but that's really because of them not being able to get enough oxygen in, and obviously if there's not enough oxygen, you become lightheaded, and that tends to lead to confusion. So let's see here, analysis and nursing diagnosis would be ineffective airway clearance related to copious tracheobronchial secretions. We also have activity intolerance related to oxygenation perfusion, and we also have risk for deficient fluid volume related to fever and dyspnea. So with the symptoms of the fever and chills, you tend to burn off more calories, and your fever itself will burn off more fluids, which will make you dehydrated and obviously make you short of breath. So. The nursing care planning and implementation, so you're encouraged coughing and deep breathing after, I believe that is chest pulmonary therapy, chest physical therapy, where they actually do the percussive pounding on your chest. You'll split your chest as needed, because obviously the more you cough, the more your chest will hurt. You're going to collect a sputum for culture and sensitivity. You're going to increase fluid intake to 3 liters a day, because again, like I said, if you drink more and more fluids, that will thin those secretions. The thinner they are, the easier they're able to cough up. You monitor for signs and symptoms of respiratory distress. You're going to plan rest periods. These people tend to get very tired, so if they're going to walk, wait until they've waken up from a nap and then walk them, and then bring them back to the room and sit them in the chair and give them periods of rest before they have to do something else. Instruct the patient to cover nose and mouth when coughing, because again, this can be definitely transmitted from one patient to another, so you want to keep that at a minimum. All right, so nursing care planning implementation, you're going to administer antibiotics as ordered. You're going to teach preventative measures, which are going to be your flu shot and your pneumonia shot. You're going to encourage nutrition and fluids, because they can keep up their strength. Avoid respiratory irritants, and obviously we talked about the vaccinations. So, and obviously you're going to evaluate what you did to see if it worked. And this right here is a little mnemonic for pneumonia. So you've got the obstruction of the bronchioles, you have decreased gas exchange and increased exudate. The symptoms are cough, fever, chills, tachycardia, tachypnea, and dyspnea. You've got pleural pain, you've got the malaise, you've got respiratory distress, and decreased breath sounds. So again, your lungs fill up, it's very hard for you to be able to breathe. Lack of breathing leads to anxiety that will increase your heart rate and your breathing patterns. So it will have a productive cough, which is green and yellow. They have this streptococcal infection, which is really what it's called. You have yellow or blood streaked. That will be the staphylococcal infection. So doctor's orders for diagnosis is sputum culture, chest x-ray, and again, you're really going to treat the signs and symptoms, give them an antibiotic, and wait for it to get better. All right, so the next one is going to be tuberculosis, or TB. I, about 2 weeks ago, took care of a patient, took care of her all day long without a mask or any other protective equipment because she was really there for the flu, and I swabbed her nose and come to find out that she was positive for influenza B. Then the doctor came by and they said, you know what, we think that she might have TB. So after I spent 8 hours with her with no mask, we transferred her to a reverse isolation room. Where then they started wearing the mask. I did discharge her on Friday after I hadn't seen her for about a week or so, and find out that her TB test and everything that they had done for her to diagnose her, to rule it out, had come up negative. So it was a positive thing for not only her, but taking care of her for 8 hours or so and no mask kind of makes you a little worried. So. All right, so let's see, etiology and pathophysiology. Lung infection caused by Mycobacterium tuberculosis. It's an acid-fast bacillus. Spread is via airborne droplets. Predisposing factors include debilitating diseases like alcoholism, diabetes, HIV. Causes is fibrosis and calcification of the lungs, and it is resistant to strains. So what I found on my internet and your Iggy book is that TB is potentially a serious infection disease that mainly affects your lungs. The bacteria that causes tuberculosis are spread from one person to another through tiny droplets released into the air via cough and sneezes. The reason why this is very, very important, and what I want you to take away from this this part of the slides for TB is that you can only get it by people coughing and sneezing. It is completely contained in the droplets, but it's also contained in droplets, and you have to be in a very, very close proximity to people. Usually it's your people who are living in homes with lots of people, inmates in jails because they're obviously in close proximity, people who live in nursing home or skilled nursing facilities. It's groups of people who live together is where it usually spreads from one person to another. And that's very important because when I took care of the lady a couple weeks ago, I was kind of worried, but I wasn't. She was coughing and sneezing and stuff, but she was doing the typical precautions of covering her mouth and using tissues and washing her hands and stuff, but you never know. So there's different types of TB. They have a latent TB, which is, you have the TB infection, but the bacteria remain in your body as an inactive state and causes no symptoms. You also have an active TB, but it is the condition that makes you sick and can be spread to others. Signs and symptoms usually include coughing that lasts 3 or more weeks. We've got coughing up blood. We've got chest pain, pain with breathing or coughing, unintentional weight loss, fatigue, fever, night sweats, chills, loss of appetite. The lady that I took care of last week or the week before had all these symptoms, but if you look at these symptoms, they tend to simulate or kind of mimic the flu. So you really have to kind of do a lot of tests in order to rule out that it is the flu and that it's not TB. So according to the Centers for Disease Control and Prevention, it recommends that people who have an increased risk of TB be screened for latent TB infection. This would include people with HIV and AIDS, IV drug users, those in contact with infected individuals, and healthcare workers who treat people with high risk of TB. That's why you get a TB test every year, is to make sure that you either don't have the latent TB or that you don't have active TB. And I mentioned this before, although tuberculosis is contagious, it's not easy to catch. You're more likely to get TB from anyone you live with or work with than from a stranger. So most people with active TB who've had appropriate drug treatment for at least 2 weeks are no longer contagious. So that's very important too, because we do get the patients that have come in and they've been on their antibiotics for a couple of weeks, and people who are not in the know get very panicky and they tend to overreact, which isn't always a bad thing. But again, if your patient who has TB has been on antibiotics for a couple of weeks, they're no longer contagious. So keep that in mind. So for weakened immune systems. A healthy immune system often successfully fights the TB bacteria, but your body can't mount an effective defense if your resistance is low. So if you actually have HIV or AIDS, diabetes, end-stage kidney disease, cancer, are on cancer treatment, uh, drugs to prevent rejection of organs, or some other drugs that are used to treat rheumatoid arthritis or Crohn's disease or psoriasis, tend to weaken your immune system. So those people are the ones that are at a higher risk of getting TB. Other ones would be those who are less fortunate, as far as especially the impoverished or substance abusers. They tend to not necessarily be an increase of getting it, but once they do, the lack of medical care or the substance abuse or the tobacco use itself will cause their immune system to be weaker, so the TB actually takes over. So also, I brought this up before, healthcare workers living or working in residential care facilities or living in refugee camps or shelters. It's the close proximity is the reason why these people tend to spread it from one person to another. And what else did I put? Let's see here. So as far as determining whether or not people actually have it, they'll do a chest x-ray, they'll do a TB test. They'll also do something called a quantiferon TB gold test, which what we use at the hospital. It's a blood test. It takes about 3 days to get back, and it actually will show whether or not you actually have the TB bacteria in your system. They will also do, as I had to mention, the chest x-rays. They'll do sputum tests to find out if it's positive for TB. The most common type of TB drugs, and I don't want you to memorize them, but just be aware of them, is the rifampin, and they also have the ethambutol and the isoniazid medications. These are medications the patient has to take for a very long time. They have to be on it for, I believe, 6 months in order for it to be effective and actually get over it. But these medications cause nausea and vomiting, weight loss, your skin will turn yellow, your urine will turn very dark, and you'll be very feverish all the time. These people tend to stop taking their medications because of the side effects, especially the nausea and vomiting. I mean, it happens all day long. They make you very sick. And for 6 months, I'm not quite sure if I would be able to do it. So with that, you know that if you stop taking antibiotics halfway through the regimen, your disease process, or let's just say TB, will come back. It'll come back actually stronger, and then you eventually will not be able to find what could be as effective if you just took them for 6 months. For us in the hospital, if we're actually exposed to TB patients, we have the option of taking the medications for 6 months to make sure we don't get it. But again, the symptoms are so horrific that I'm not quite sure if I really want to feel like that for 6 months to potentially just prevent getting the TB. So for a lovely lady that I had a couple weeks ago, it was positive that she was negative, but if she would have been positive, I probably would have waited until I got symptoms or before I actually took the medication. So, but that's just me. Let's see here. So for those who have TB, they tell you to stay home. They want to make sure that the room is ventilated, cover your mouth when you cough or sneeze, and wear a mask. So I think that's the best thing you probably could do is wear a mask and keep it away from everybody else. In the hospital, we use the N95s, and that does pretty well. So. And I think that is about it. What I did find out too is that I actually work with a lot of Croatians. They have actually been vaccinated against TB. I don't know enough information about it, whether or not the statistics and if it works or not, but the ones I work with who are that have been immunized, they don't do the TB skin test because it will come up positive because they have the antibiotics for it. But the chest x-rays is usually your second defense. So. Let's see here. What else do we have? Talked about the signs and symptoms. We talked about the subjective and the objective. We talked about the skin test, which is also known as a PPD. You're going to do a bleb. That's how you actually administer the medication. So it's, let's see here. I believe the PPD is actually a blood that you use in its intradermal, and you actually administer it. You usually give it about, let's see here, 48 to 72 hours. If it actually has a reaction to it, the first picture that you see on the upper right is your reaction. I actually don't have a reaction to the test itself, but I have a allergic reaction to the actual serum. So I will get a big welt the size of a baseball on my arm where they actually do the skin test. And about the 72nd hour is usually when it finally completely goes away and it looks normal, and then I have somebody rate it. So, but I've had chest x-rays and those come up negative too. So again, you're going to do a sputum culture and find out if that's another way of finding out whether or not they have TB. All right, so let's see here, collaborative care. We got drug therapy. Again, I mentioned that it was long-term at 6 to 9 months. The first phase is 2 months. The second phase is 4 to 7 months. You'll do combination therapy, which would be the isoniazid and the rifampin. You'll do the isoniazid, rifampin, or the ethambutol, or the isoniazid, rifampin, and the pyrazinamide. Must comply with the drug regimen, avoid antacids and alcohol and sunlight. Those will probably not necessarily deactivate them, but make them less beneficial or actually less likely to work. All right, so anti-tubercular drugs, the first line of medications, you have them here. Again, you're going to take them from anywhere from 6 to 9 months, and like I said, the signs and symptoms are very horrible. So people tend to not last the 6 to 9 months as far as being able to take them and keep them on that regimen. So, all right. So for collaborative care, we've got bed rest. We will put them in isolation. You'll put them on airborne precautions. It's a specially ventilated room, so you open up the door, and it literally sucks the air out of the room and into a vent in the ceiling. The patient, if they're going to go to test, will wear a HEPA mask, or for us going into the room, we'll actually wear a mask. They have prophylactic therapy for immediate contact, which is 6 months to a year. I have been in contact with several PTB patients. I have yet to take the medication, but again, that's kind of my own choice and a risk that I take. We have nutrition, which is high protein, high vitamin, supplements of B6, and that's pretty much about it. So, keep yourself very healthy, take your vitamins, eat well, and that's the best way you can do it, whether it be the flu shot, the pneumonia shot, and keeping yourself healthy is what's going to keep you from getting it. So for nursing care, we have an assessment, which you'll assess for fatigue, anorexia, fever, night sweats. You'll also check for color and consistency of the sputum. You also listen to the lung sounds. Nursing diagnosis would be activity intolerance related to impaired oxygenation, and you have non-compliance related to long-term nature of therapy, the medication side effects. So again, these people, I can't stress enough, these people just can't last the 6 to 9 months taking these medications and feeling the way they do. So for nursing care, we have planning and implementation, provide rest periods, encourage coughing and deep breathing, and obviously dietary teaching. Teach importance of adhering to medication schedule and the importance of follow-up. So not only will they take a medication for 6 to 9 months, but they're also going to follow up with their doctor every couple months to make sure that they are getting better and that it's not getting worse. And again, you're going to evaluate the patient for the interventions and the plan that you've done. All right, so next we're going to cover COPD, which is chronic obstructive pulmonary disease. COPD is actually a generic term or an umbrella, if you want to call it that, which will also cover chronic bronchitis and emphysema. So when you have a patient who says they have COPD or they have a diagnosis of COPD, usually it's going to be chronic bronchitis or emphysema, or they can actually have both. And we'll go over those individually. So here's some pictures. All right, so now that we've got the slides straightened out, All right, so what I found on the internet as far as COPD. So COPD refers to the lung diseases of emphysema and chronic bronchitis. The symptoms of COPD, which are very generic, and like again, they can actually cover both, but they are pretty good as far as seeing them in both patients. So excuse me. So with COPD, you have shortness of breath, especially during physical activities. You'll have wheezing, you'll have chest tightness, having to clear your throat first thing in the morning due to excess mucus in your lungs. We have chronic cough that produces sputum that may be clear, white, yellow, or green. We have blueness of the lips and fingernails, or cyanosis as they call it, frequent respiratory infections, lack of energy, and unintended weight loss. I think that was it for that one. So how does someone actually get COPD? Usually it's from smoking or other irritants. So the vast majority of cases for COPD is lung damage that is caused by long-term cigarette smoking. But there are other factors such as generic susceptibility, which is about 20% of the people with COPD. They also have other irritants, which is cigar and cigarette smoke. We've got air pollution, workplace exposure to dust, smoke, and other fumes. So complications of COPD include respiratory infections, high blood pressure, heart problems, lung cancer, and depression. I think the depression is really more of the inability to really kind of do what you were able to do before, and not necessarily coming to terms with what you're restricted to. In order to actually determine someone has COPD, they'll actually do a pulmonary function test. This is a spirometer that will function, that will actually test their lungs. They'll also ask to blow into a large tube connected to a spirometer, and that determines whether or not they're able to blow off the CO2. They'll do a chest x-ray, which will actually show emphysema or chronic bronchitis. They'll do a CT scan, which will actually detect emphysema and determine if they're eligible for surgery to be able to correct some of those problems. And they'll also do an ABG, or an arterial blood gas, to determine whether or not they're bringing enough oxygen and actually blowing off enough carbon dioxide. So as far as medications, let's see here, doctors use several medications to treat symptoms and complications of COPD. The biggest ones are really the bronchodilators. These will actually relax the muscles around the airways, which will allow them to breathe deeper. They have, according to this, short-acting bronchodilators include albuterol, Xopenex, and Atrovent. Let's see here, there's Spiriva, and I think that was it. There's a million of them, but the ones that I see on this page is really what were probably the most common that I've seen in the hospital. You also do inhaled steroids. You'll do a combination of different inhalers. What may work for one person may not work for the other, or not work as well, and then you'll find another inhaler that will kind of complement the other, so they'll work together better. They'll do oral steroids. They'll also do theophylline and antibiotics based on people with COPD tend to get a lot of infections, so they'll put them on antibiotics, whether or not it's because they are sick, or people who have COPD tend to know when they're getting sick, and they'll usually do the antibiotics earlier, and just to kind of make sure that it doesn't get worse. So as far as therapy, they'll do oxygen therapy. Usually they'll put somebody on oxygen that doesn't, in late stages, they don't breathe real well, so they'll usually put them on 2 liters of oxygen. They'll do pulmonary rehabilitation, which is basically teaching them how to breathe better, and basically what they are breathing and not blowing off, make it work better for them. There is always surgery, but I don't want to get too deep into that. Just know that there's a possibility of lung transplants if it gets that bad. But I think that's pretty much it for COPD. So now we'll get into more of the acute and chronic bronchitis and the emphysema. All right, so for chronic bronchitis, we've got the inflammation of the lower respiratory tract, which is characterized by excessive mucus production and cough. It can be acute, which is usually viral or bacterial infection, and then we also have the chronic, which is without infection. So, for acute, usually you've had either the cold or the flu or some sort of drainage that has drained into your chest and that has caused some sort of viral or bacterial infection there. If it's viral, there's not a whole lot you really can do except treat the symptoms. With bacterial, you can take antibiotics, and again, you'll do that, but also treat the symptoms. And with chronic, you're going to go a completely different direction. And let's see here what I found on the internet. Let's see here, bronchitis is an inflammation of the lining of the bronchial tubes, which carry air to and from your lungs. People who have bronchitis often cough up thickened mucus, which can be discolored, and bronchitis may be either acute or chronic, which we talked about. So signs and symptoms are a cough, production of mucus, which could either be clear, white, yellowish, or green. I think the different colors or the darker that it gets, the more infection you have. If you wake up in the morning and you're coughing your head off and you're coughing up clear or even white stuff, it's not a big deal. It's usually, again, as a symptom of something else, which is usually more the flu or some sort of head cold. But once it actually turns color and actually becomes yellowish or green or even brown, that tends to be more of an infection. You also have fatigue with it, you have shortness of breath, you have the slight fevers and chills, and you have the chest discomfort. So again, it really just mimics the flu, but it's just now has landed into your chest. If you have acute bronchitis, let's see here, you may have a nagging cough that lingers for several weeks. So in fact, I work with somebody who had bronchitis and she had gotten over it, but then once she got over it, she still has this lingering kind of cough in the morning and the constant, clearing of her throat. Let's see here, chronic bronchitis, it's actually a productive cough that lasts at least 3 months with recurring bouts occurring for at least 2 consecutive years. So in order for you to be, and it's kind of strange because if you had a bronchitis and it's from the flu or from other things and you've gotten sick and you got over it, okay, I get that. With chronic bronchitis, for me, it's, you've done everything, you've been sick for a while, you just keep getting sicker and eventually it's just chronic. But according to this, it's recurrent bouts of bronchitis that you've had for over 2 consecutive years. So I guess you have to really have bronchitis for a long time before it's really truly diagnosed as chronic. Again, I think they'll really treat the symptoms as best they can and just kind of, I think everything just leads up to that 2-year mark. So. All right, so let's see here. We were talked about that the acute bronchitis is caused by viruses, and you really just treat the symptoms. Things that could cause it would be cigarette smoke, low resistance, as far as immune system being able to get over it quicker, exposure to irritants, whether it be pollution or secondhand smoke or whatever. They also have something in here for gastric reflux. So a lot of times people who lay flat and sleep will get the acid reflux, and that will cause burning more in the throat. But that constriction will also cause the irritants to affect the lungs. So with that, it'll cause your bronchitis. All right, so let's see here. I think that was about it. Chest x-rays, sputum test, pulmonary function test will determine whether or not it's acute or chronic or another issue. If it is a chronic issue with bronchitis, which antibiotics, cough medicine tends to work. And again, they'll probably use some sort of inhaler or SVN treatments in order to help with the symptoms. And I think that's what I found about that. All right, so here's some pictures of an inflamed airway. They have the normal bronchus at the top, and they have the inflamed bronchus at the bottom. So you can see that little black spot on the right side. That's actually the airway. So again, we have the normal bronchi, and we have something with, the normal bronchi with bronchitis. So it really does affect your breathing. And again, we mentioned this with the other breathing disorders. The inability to breathe and feeling you're suffocating has got to be a horrible experience, and that really does cause a lot of anxiety. So when you're taking care of patients who sit up and they can't catch their breath and they're acting all crazy, you really have to sympathize with them, because there's not a whole lot you really can do besides give them, their steroids and their breathing treatments, and put oxygen on them. But again, that takes time. So for people who feel as if 1 minute is really lasting a half hour, it really is. I mean, it takes a while for this stuff to work and for them to calm down and relax and feel okay about the fact that they're not going to suffocate to death. So. All right, so for emphysema, let's see here. Etiology and pathophysiology is an obstruction caused by hyperinflation of the alveoli or trapping. It's a loss of lung tissue and elasticity and narrowing of small airways. And one of the things you can do is the pursed lip breathing, but we'll discuss that in a couple slides. So what I found in the trusty internet and in your EEG book is, let's see here, emphysema is gradually damages the alveoli of your lungs, making you progressively more short of breath. Emphysema is one of the several diseases known collectively under the umbrella of COPD, and smoking is the leading cause of emphysema. So, and this is where I'm going to read a little bit more to you, because I think it explains it pretty well. So your lungs alveoli are clustered like bunches of grapes. In emphysema, the inner walls of the air sac weaken and eventually rupture, creating one larger air space instead of many small ones. This reduces the surface area of the lungs and, in turn, the amount of oxygen that reaches your bloodstream. So when you exhale, the damaged alveoli don't work properly and old air becomes trapped, leaving no room for fresh air. The treatment may slow the progression of emphysema, but it can't reverse the damage. So if you actually look at this picture on your PowerPoint, on the bottom right is the normal alveoli. So when you're breathing in and out like you are right now, you're exchanging the oxygen for carbon dioxide. The picture above it, because of emphysema, those air sockets, it's almost like bubble wrap. You can actually, if you do it right, you can actually go from being small little bubbles and popping them to actually causing bigger ones by releasing some of that pressure from one to the other. Well, those sacs that have now moved from being grape-like clusters to bigger and in one as opposed to five, is now not allowing that actual air to escape. So you're able to inhale and bring in the oxygen, you're just not able to blow off that CO2. So let's see here, what else we got? Factors that increase your risk of developing emphysema include are going to be, let's see here, smoking, which we've talked about before. We've got age, especially with those who have actually smoked and stopped. Eventually it will catch up to them. Exposure to secondhand smoke, occupational exposures to fumes and dust, and exposure to indoor and outdoor pollution. Let's see here. People who have emphysema are most likely to develop a pneumothorax, which is a collapsed lung. Will also develop heart problems, which, let's see here. Emphysema can increase the pressure in the arteries that connect the heart and the lungs. This can cause a condition called cor pulmonale, in which the section of the heart expands and weakens. Let's see here. Emphysema can also cause large holes in the lungs. According to this, it's giant bullae. Some people with emphysema develop empty spaces in the lung called bullae. Giant bullae can be as large as half the lung. So you figure at that point, you're really not moving any air in or out, and you're really down to 1.5 lungs. So let's see here. Things you could do is to obviously stop smoking. And let's see here. As far as testing, they're going to do a chest x-ray. They'll do lab test, which they'll probably do an ABG. And they'll also do a lung function test to find out how well you really are doing. With medications, it's going to be bronchodilators, inhaled steroids, and antibiotics. For therapy, it's going to be pulmonary rehabilitation, nutritional therapy. Let's see here. According to this, nutritional therapy will receive advice about proper nutrition. In the early stage of emphysema, many people need to lose weight, while people with late stage emphysema need to gain weight. So I think that what they're saying here is if you keep a normal body mass for your frame, that's less weight that's on your chest to be able to be able to breathe. So we had a patient this last weekend that was 457 pounds. He couldn't lay flat because of the weight of his chest was too much for his lungs, and he couldn't actually take the deep breaths because of the weight. Plus his neck was the size of probably my thigh, or even bigger. And the weight really had a lot to play with it, in the sense that if he was a normal size for his frame, then he wouldn't have to worry about that being one more factor in not being able to breathe real well. See here, they also do supplemental oxygen. So some of these people either wear oxygen 24 hours a day, or some people actually wear oxygen just at night. So, and I think that was it for what I found on the trusty internet and the Iggy book. All right, so let's see here. All right, so for signs and symptoms that are subjective, you will see fatigue and weakness, dyspnea, headache, impaired sensorium. And with signs and symptoms that are objective, you'll have the orthopnea, expiratory wheezing, and you'll have a cough. You'll see the barrel chest. The barrel chest is due to the accessory muscles becoming wider, and that's what causes your chest to be bigger. They have cyanosis, clubbing of the fingers, use of accessory muscles, which again we talked about that, it causes the barrel chest, and the pursed lip breathing. So basically, you're going to, if you sit in your chair right now, you take a big deep breath, and then when you actually put your lips together, and almost like you're going to whistle and breathe all that air out as slowly as you possibly can. It seems tedious, but that's what people who have emphysema have to breathe like all the time. In order for them to blow off as much CO2 as they possibly can, they need to exhale very slowly and deliberately in order to get as much as they possibly can. Because if they can get it out, that means the next time they take a deep breath, they can actually replace that with good oxygen. If you can't blow off the CO2, then you can't actually inhale enough oxygen to, because there's just not enough room. So. Let's see here. They'll also check for ABGs. They will have an increase of PCO2 and a decrease in PO2. We talked about diagnostics. You'll do a pulmonary function test. The labs will be an ABG. And they'll also check for red blood cells and polycythemia. We've mentioned this before with red blood cells. The less you have, the less oxygen you carry. So for these people, you want as much as you possibly can in order to carry more oxygen. They need all the help they can get. So whether it be a lung problem, a cardiac issue, or a blood issue, those need to be corrected in order for them to continue to survive and breathe as best as they possibly can. All right, so for collaborative care, we've got patients with COPD become accustomed to a residual carbon dioxide level, which is hypercarbia, and do not respond to high CO2. Concentrations is the normal respiratory stimulant, so they respond instead to a drop in oxygen concentration in the blood. Therefore, this is very important, watch O2 administration. Hypoxemia becomes the drive to breathe, so too much O2 will knock out this drive. If you put them on oxygen, which is typically 2 liters or less, they will bring in exactly as much as they need or less, but not more than they actually need. If you give them too much oxygen, that their body does not need to breathe as much, so that again knocks out their ability to breathe. And I'll explain this in class. It's a little bit easier to actually show you than it is to describe it, but this is very important to remember. So if you have a patient that's on, let's say, 2 liters and they're having a hard time breathing, just leave it, because their body will actually try to compensate for it, and they will actually breathe much better on their own. If you turn them up to 3, 4, 5 liters in order to get them higher, because you think you're doing a good job by allowing them to relax, actually put more oxygen in them and stuff, it essentially their body doesn't have to breathe as much because you're already doing it for them. So again, keep that in mind. So typically it's 1 to 2 liters is the maximum O2 delivery for these patients. Something else I was going to tell you and I forgot. Oh, their pulse ox. These people tend to have a pulse ox of about 88 to 89%. That's normal for them. So don't kill yourself trying to fix a problem that's not fixable. So again, 2 liters of O2, and they usually live around 88 to 89%. So for collaborative care, you're going to have drug therapy. We got the bronchodilators, we have the corticosteroids, the mucolytics and the expectorants, and we have antibiotics. So again, you're doing whatever you can to whether it be open up the lungs, decrease the inflammation of the lungs, or thin out the secretions of the lungs, or keep them from either getting too thick, or again, if they get thick enough, those cause infection, and that will be even worse. So you have to do whatever you can to prevent these things from happening. So oxygen therapy, we talked about that. Respiratory therapy, SVNs, CPT. You want to make sure they have a high protein, soft diet, small frequent meals. Those who can't breathe real well, it's hard for them to do activities. So for them to eat and breathe at the same time, it's very hard. So if you do small frequent meals, especially soft diets, they don't have to keep eating that tough steak. You're trying to gnaw on it and breathe at the same time, which is already impaired. So if you give them something that is actually easier to chew and swallow, that allows them to chew, swallow, take a breath, chew, swallow, take a breath, not chew, 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 chew. Okay, take a deep breath, and then eventually chew it and swallow it. So think about that way. So for assessments, you're gonna check for a history of increased signs and symptoms during early morning in cold weather or when sleeping and smoking. You want to find out when does their exacerbation start, what really triggers to them get sicker. Check for the breathing patterns. You're going to look for abdominal activity. You're going to look for pursed lip breathing, asynchronous and accessory muscles, and breath sounds. And let's see here, you're going to do frequency of respiratory infections and evidence of acute and chronic hypoxia. So for nursing diagnosis, it's going to be ineffective airway clearance related to bronchospasm and secretions. You're going to have activity intolerance related to oxygenation and perfusion mismatch. You'll have powerlessness related to loss of self-care capability, because again, these people have low activity, so doing their ADLs or taking walks or walking the dog or doing dishes, things that they used to do before is not something that they're able to do anymore, or it's going to be very difficult. You also have a nursing diagnosis of anxiety related to oxygen deprivation. Again, if they can't breathe, then they get very anxious. The more anxious they get, the more they breathe faster, and then the more faster they breathe, the less oxygen they're getting in, the less they're able to actually blow off. So it's a snowball effect. So for planning and implementation, you're going to advise smoking cessation and other external irritants. You're going to do respiratory exercises, teach use of inhalers and spacers, pace activities and avoid overexertion. You promote adequate rest, nutrition, and fluids, and encourage close medical supervision. Again, they can't live out in the country somewhere and have some sort of COPD or emphysema exacerbation and not be able to breathe and have to drive to the hospital a half hour away. They'll be dead by then. We also have nursing care planning and implementation. So you're going to teach, you're going to maintain resistance, adequate nutrition, fluids, and vaccinations, avoid exposure to infection, avoid use of sedatives and hypnotics. Again, these people already have a hard time breathing, so give them a little bit of morphine, which will depress their respirations even more. If you went from being cyanotic at 12, you're going to be blue with 8. So definitely start very, very low on narcotics and sedatives, because like I said, you wipe out their ability to breathe just with a little bit of pain medication or anything that will sedate them and it'll kill them. So early signs and symptoms of infection. Most of these patients have lived with this long enough. They know when they're getting pneumonia, or they know when they're getting some sort of infection. They'll tend to call the doctor, and the doctor will believe them and know that they know what they're doing, and will call in antibiotics or give them on something to be able to keep it from getting bad. So, and again, you're going to evaluate and find out if all this stuff had worked. All right, so we have metered dose inhalers. It's used in patients with chronic obstructive pulmonary disease, or COPD, and asthma. It provides a fine mist to the lungs. Coordinating a quick puff from the inhaler and taking a deep breath can pose a problem for some clients. So with the inhaler, you're basically going to stick it in your mouth, you push down, and you take a deep breath. For the elderly, this tends to be a little bit harder because it's more of coordination. But if you push down and you don't really take that deep breath, or if you're blowing instead of inhaling, you're really blowing all that stuff away. You really want to be able to push it down, the mist comes out, and you just breathe as deep as you possibly can so it gets as deep as it can get. They also have spacers, which is a holding chamber which allows the correct distance from the mouth and taking the deep breath to get the medication into their lungs. This is actually a little bit of tube that actually fits on the mouthpiece. They push it down, it goes into this tube, and then it allows them to take a deep breath so it's not dispersing into the air and not being able to get all the medication they need. If the spacer is missing, a temporary one can be made by rolling a 6 to 8 inch piece of paper. Very interesting. Or you can probably also use a toilet paper roll, but if you have toilet paper rolls laying around the house. All right, so let's see here, MDI with spacer instructions. So remove the plastic cap to the MDI and the cap on the spacer. Insert the MDI into the back of the spacer. Hold the two together and shake. Monitor pulse and breath sounds before and after therapy. Instruct the patient to take a minimal inspiration and exhale completely. Place the MDI and spacer near the patient's mouth and have the patient inspire slow while activating the MDI. So you don't want to just push it down and just take a big deep breath. You really want to be able to push it down and actually breathe in as slow and as deep as possible so it actually gets in and coats as much as it possibly can. So note, a maximum slow deep breath held for 5 to 10 seconds is important to proper usage of the MDI and to improve drug deposition. Yes. So repeat step 4 and 6 for each puff, waiting at least 30 seconds in between puffs. And usually it's 1 to 2 puffs, not more than that. So you have powdered inhalants. This right here is Advair. It's the discus. So what you basically do is you, it has a little bit of a trigger on the side or on the top, and basically you push that down. It actually breaks the capsule. You stick it up to your lips and you take a big deep breath. So it's basically just like the MDI, but it's more of a disc as opposed to a cartridge or a cylinder. So these are all the different medications. So let's see here. You've got fluticasone, corticosteroid, you got salmeterol, which is a bronchodilator, and patient should rinse their mouth after administering the medication. And you should do this because it will cause thrush. So if you, thrush. If you actually have them take a big deep breath after they've pulled the trigger, and then when they kind of give them 30 seconds or so, and then give them a little bit of water, they rinse out their mouth and they spit out the water. All right, so SVNs, which is small volume nebulizers, usually administered by respiratory therapists, but nurses need to know how to do this because I've actually had to do this before. So, your respiratory therapist is busy or you need this right this second, you got to do what you got to do. The pictures are really good. What I think was interesting is that this gentleman is actually doing it outside, which seems kind of weird. So anyways, but it is usually it's put in a little in the middle picture, in that little container towards the bottom before the tubing. You put all the medication in there, and then you screw on the cap, and then you turn the oxygen as high as you possibly can, so that way it actually can cause the mist, and that would cause the breathing, which seems kind of counterintuitive because we told you that we don't want the oxygen built above 2 liters for COPDers and emphysemas. But for this case, you need that to be high so that way they can actually do the mist and actually breathe. But it's also opening them up. So for the short term, they probably are able to do this because it allows them to breathe a little bit deeper and open them up a little bit better. And that is the blend of the PowerPoint. So let me know if you have any questions. In lecture, we will go over your medications. So fill out your little ATI medication forms, and we'll go over those, and that's about it. So let me know if you guys have any questions. Thank you very much.